Welcome. I want to just take a moment to welcome everyone to our webinar. We actually have a two-part webinar. I'm going to be starting off with the first webinar, which really is going to set the stage for what comes next. So this project is really a collaboration between New York City Health and Hospitals, the Correctional Health Services, and the Center for Latino Adolescent and Family Health. I want to just introduce myself. I'm Vincent Guillermo Ramos. I am a professor at New York University. I primarily teach in the Silver School of Social Work here at NYU, but I also am affiliated with the schools of nursing and public health. I direct a pilot and mentoring corps, which is part of a center called the Center for Drug Use and HIV Research, CEDAR, which is a P30 NIDA-funded center. And I also am the founder and director of the Center for Latino Adolescent and Family Health, which is sort of the core partner with New York City Health and Hospitals in developing and delivering this webinar. Just as a way of making this more personal, I want to share that a lot of what I'm going to be talking about is not just something that I think about sort of theoretically. I also am directly involved in caring for adolescents who are living with HIV. I'm a clinical nurse practitioner that sees young people who are at risk for living with HIV at Montefiore Medical Center at the Adolescent AIDS Program. And so a lot of what I'm going to bring forward actually is a combination of my research, my scholarship, and also my direct practice work in working with Latino young people living with HIV. So I think I've started by kind of sharing a bit about sort of the background of the curriculum. I'm going to say more about that in just a second, but I wanted to make sure that I thank all of the partners. And so certainly the lead organization here is New York City Health and Hospitals in the Correctional Health Services. I want to take a second to, in particular, thank Allison Jordan, whose leadership in really writing and developing the application with her team and also implementing the project. None of this would have happened if it were not for Allison. But I also want to acknowledge Janet Wersima, who's part of Allison's team. The two are some of the primary architects of the content that you're going to be hearing today. And then also the funding source. The grant was received by New York City Health and Hospitals Corporation Correctional Health Services, but it was funded through the U.S. Department of Health and Human Services through a special, what's called the SPINS program. And so these are sort of special projects of national significance. And there was a particular mechanism which is called culturally appropriate interventions of outreach, access, and retention among Latino populations. And so for this particular grant, the population that we're going to focus on is Puerto Ricans. However, I do want to say that much of what I'm going to be saying and sharing is actually relevant to the broader Latino community. Sometimes I'll talk about Latinos as a whole. Sometimes I'll zoom in and really highlight Puerto Ricans. And the reason for that is that some of the other SPINS projects deal with other specific Latino groups, but I wanted to both address issues that are specific to Puerto Ricans and also make the curriculum relevant for those of you that may be working with Latino populations that are not Puerto Rican. Here's a bit about what we're going to be covering in this first webinar. This is our agenda. So I'm going to spend a little bit of time talking about the purpose of the curriculum, provide an overview, and talk about the target audience. But I'm also going to then go right into what we call Module 1. Module 1 is really designed to look at issues related to healthcare utilization among Latino individuals living with HIV. And there are some key concepts that we're going to review. And so some of those key concepts include issues related to transnationalism, which I'll explain a little bit later. Cultural competence, which is certainly, it's sort of the center of what we're really talking about. And so a lot of what this curriculum is designed to do is really address issues of cultural competence. We'll look at something called the socioecological model. And then we're going to look at what we mean by Latino culture and trying to understand Latino culture. And again, we'll sort of walk a balance between Latinos and Puerto Ricans. I think what's really nice about this project is that in putting it together, we didn't want folks to just have a set of things that we were asking them to sort of know or memorize, or facts that might or might not be relevant to a particular Latino individual. We wanted to actually kind of review some of that knowledge and some of those facts, but also provide frameworks. And so we provide in our curriculum 4 conceptual frameworks or models that we think are going to be really useful in terms of trying to apply culturally competent practice to improving outcomes among individuals who are Latino and living with HIV and AIDS. Here's our purpose. You can see here that the curriculum serves as a guide for health and social service providers. It's a very broad definition. When we say providers, we mean anybody who is responsible for caring for an individual who is Latino and HIV positive, anyone who works in any way in the criminal justice system and has contact with people living with HIV. It really, is intended to be everyone. So not just doctors and nurses and social workers, but counselors and substance abuse specialists and patient navigators, case managers, anybody who is really working with an individual who's Latino and living with HIV. We also want to make really clear that we're trying to address the needs of folks who have criminal justice involvement. And so people who are currently in jail or prison, or folks who at some point in their life, who for many of us, we may be working with individuals who are not incarcerated right now, but have a history at some point of being incarcerated, and they may be now sort of receiving care at our organization. And so we want to think about what makes criminal justice involvement a unique experience, and how living with HIV and being Latino and having a specific history of criminal justice involvement could potentially shape things in a way that doesn't foster improved outcomes. And so at the bottom of this slide, you can see that our overall learning goal, and this is really consistent with what we call the HIV/AIDS national strategy. We're trying to reduce the number of new HIV infections. That's a priority for the United States. We've made great progress, and I will talk a little bit later about some of the progress we've made, but we've made great progress as a country, and for that matter as a world, at reducing HIV incidence across our planet. However, we do know in the United States and in many places in the world that it's still the case that we have too many new cases of HIV. And we also know, despite all of our improvements in treatment, and both in terms of preventing HIV as well as helping people living with HIV to be virally suppressed, there still is morbidity and mortality that's associated with HIV disease. And that there are disparities that influence certain ethnic racial groups more so than others. And so we want to have this curriculum help to address issues of reducing new cases of HIV infection and helping to reduce HIV-related morbidity and mortality. There are 3 modules in the full sort of curriculum. There are actually 2 webinars. The first one is what we're doing now, and we're going to sort of jump in a few minutes with the formal sort of introduction of the first webinar and the first module. But then the second webinar will really look at modules 2 and 3. And you can see here that I mentioned earlier that increasing healthcare utilization among Latino HIV/AIDS, individuals living with HIV/AIDS is sort of the focus of our first module, but then we're going to look at sort of an overview and an epidemiological profile of HIV/AIDS among Latinos in our country, and then we'll look at what we call the interconnected epidemics of HIV among Latinos and incarceration and make some connections. The curriculum is designed to build, and so we want to encourage you to actually listen to today's webinar, but also to listen to the follow-up webinar, which is webinar 2. But we also know that folks are busy, and so we invite you to pause, to stop, to complete some of it now, some of it later. And also, if there are sections that you're more interested in, you certainly can do one of the webinars versus both. But we think collectively that doing both will actually be a much richer experience. Module 1 addresses issues of cultural competence, and I'm going to introduce the 4 provider-level strategies or frameworks that are aimed at improving culturally appropriate care for Latinos living with HIV. So I mentioned already that this is targeting providers broadly defined, and so we want to invite anybody who is working with someone living with HIV who's Latino and has a criminal justice history or involvement to actually benefit from the information that we're sort of providing here. Feel free also to let us know what you think on the website where the curriculum will be posted. There's some information that will be posted there about how you can give feedback on the curriculum. There'll be a pre and a post test sort of evaluation, and all of that can be useful in you having the ability to also shape how this project develops and sort of how it gets used. So a little bit of self-reflection. I want you to think on your own about what do we mean by culturally appropriate care? And so I mentioned earlier that I am a social worker as well as a nurse and have training in public health. And I think it's pretty common for folks to bring up issues of cultural competence, to bring up issues of culturally appropriate care. But what does that really mean? And if you think about what's also being reflected on this slide, how does culture really influence our clients, our patients, the people that we're working with? So if you just kind of reflect on that, because I know for a long time, in my own career, I sort of struggled with the importance of culture. It's certainly something that I know matters to many individuals, if not all of us. But having that be reflected in how I thought about my cases, how I interact with my patients, and having culture really sort of inform how I deliver care, that was harder for me. And so I think that one of the things I really enjoy about the curriculum is that it starts to provide some concrete tools of how we can define what we mean by culturally appropriate care and how we can think about how culture might influence what we do and how we think about the people that we're working with. All right, so that was our introduction. I'm actually going to jump in, so thank you very much for hanging in there while I went through sort of the preliminary part of the curriculum. I'm going to start with Module 1, which is really looking at healthcare utilization among Latino HIV positive individuals. And sometimes I'm going to refer to individuals living with HIV, which is sort of my preferred sort of way of describing people who are HIV positive. But oftentimes providers, particularly medical providers, think of folks as being patients. So you might see on the slide, there's a reference to patients. Or for those of you that aren't necessarily medical providers, you may think of the folks that you work with as clients. And so all of those words, I'm sort of referring to the same thing. And so why don't we just jump in? So some key concepts. So the first one is this idea of cultural sensitivity and cultural competence. And so I think a lot of my own formal education really focused on cultural sensitivity. And this really was trying to make me as a provider, as a social worker, as a nurse, as a person who works with any client or patient, really recognize that there are differences between cultures and that these differences can actually be reflected in how our clients or patients interact with us as providers, how they interact with people within their same cultural group, and that these sort of differences have meaning and that we needed to try to understand them and be sensitive to them. And so I want us to think about that definition because certainly awareness of difference is important. And certainly being sensitive to what makes somebody unique and how their culture might inform how they interact with us as a provider or how they interact with others is important. But I want everyone to really focus in on the sort of lower part of the screen. And so what you see here is this idea of cultural competence. And in my view, we should be talking much more about cultural competence. And so for me, cultural competence moves beyond just sensitivity. It moves beyond understanding. It moves beyond knowledge. It includes those things. And so I'm not suggesting that we shouldn't have knowledge and we shouldn't have a sensitivity and that we don't want to understand another person's culture. But it means taking that knowledge, taking that sensitivity, and actually adapting what we do as providers, all of us. It means adapting our approach. It means delivering the intervention in a way that is responsive to the specific culture or the needs of the person who you're working with, the family, or the group that you define as being the cultural group. And so I'm going to talk about that. And I think what I want everyone to think about is that it's not enough to just have information. That information has to translate into doing something different that actually is responsive to the needs of the person who you're working with. Why should we care about this? And so cultural competence, it's critical to reducing health disparities and improving access to high quality healthcare. We know that when there's greater cultural competence, it's associated with better patient-provider communication. We know that improved communication leads to more treatment adherence, that our clients, our patients are more likely to follow through with their prescribed treatments, their regimens, their actual sort of next steps in terms of what they need to do to manage their HIV disease. We know that our patients and clients feel better about the care they're receiving, and if they feel better, they're more likely to engage in care. And we know in general there's overall improvements in health behavior and in the clinical outcomes that we care about. And so I want to suggest at the very beginning of our presentation that improving cultural competence means improving sort of what are called the HIV care continuum outcomes. And so keeping people virally suppressed, keeping them linked and engaged in their treatment, and helping people with HIV to reduce their morbidity and mortality, and also helping to reduce new HIV infections among people who are at risk but currently not infected. And so another important sort of key idea or concept is transnationalism. So, this is kind of an interesting slide. It shows the globe and there's some arrows sort of pointing in and out. And so I think the idea here is that people, wherever they may be geographically, they have connections that are to their culture of origin or their geographic sort of countries of origin, and also where they may be currently living or settled. And so these linkages, these relationships, they're multi-stranded. They actually are not just that people leave where they're from and sort of go someplace and settle there. They actually are important reference points, and they're sources of emotional and practical support. They're sources of a lot of positive things, sort of like our culture, our beliefs, what we think about the kinds of services that we might want to access, particularly based on where we're from or where we are going. And so, transnationalism really addresses this idea that there's a connection, that there's a linkage between where people are from and where they currently are, and that linkage may be going on actively and currently. So while I'm seeing a patient who may be treated where I currently am, that patient could actually have important family connections, or may actually physically go back and forth, or may be receiving certain kinds of treatments or remedies from their country of origin. There's a linkage, and that linkage needs to be understood as part of how we think about the cultural work that we do. So if you think about Puerto Ricans, and they're our case example, I mentioned earlier that we'll be looking at Puerto Ricans, we know that Puerto Ricans are US citizens, and so there's a lot of transnational experience, and that Puerto Ricans can easily move between the island of Puerto Rico and the continental United States. And historically, this has been referred to as the air bridge, the link between places like New York City and Puerto Rico, or certain target communities in Florida, or some places in Pennsylvania. But certainly there's been a long-term tradition of Puerto Ricans going back and forth between the island of Puerto Rico and the continental United States. We know that sort of cross-border activity, that air bridge experience, that it shapes how Puerto Ricans view their identity, and that these influences actually have a dramatic impact, not only on the people that are going back and forth, but the second and third generation of Puerto Ricans that may be born on the continental United States. And so, this is a good way of thinking about how transnationalism might be playing out, in particular because if you think about what's happening right now, in 2017 there was really serious, catastrophic hurricanes in Puerto Rico and in the broader Caribbean, Maria and Irma, and that there are roughly estimates of about 135,000 Puerto Ricans that have relocated from Puerto Rico to the continental United States, and that we know that Puerto Rico is actually losing or has lost a significant proportion of its population, and that this is related to hurricane-related migration. Those that remain have tended to be folks that are unable to move, or that actually are older, and they may have sort of offspring or family members that are now living in the continental US. And so again, as we think about sort of HIV/AIDS and the care continuum, and how to keep sort of Puerto Ricans, as our case example, sort of linked and retained in care, it would be really difficult not to think about the impact of Hurricanes Maria and Irma on this sort of care cascade. We know that the transnational dynamics of the Puerto Rican community will continue to be shaped by events that are likely to occur not only 2017 and what happened with the hurricanes, but also right now in 2018 and in the future. We know that it's predicted there'll be additional hurricanes, and that within itself is going to have a sort of big impact on people living with HIV. One of the things that often gets sort of forgotten is that San Juan is one of the cities in our country that actually has a high HIV prevalence. And so it's a key area, a key geographic area for thinking about how we can resolve the HIV/AIDS epidemic in the United States. Puerto Rico factors into that actually quite prominently. So another sort of self-reflection, and so I want you to think about, what are some of the kinds of factors that are environmental, that are social, that might be an obstacle or a challenge to a Latino or a Puerto Rican engaging in primary care. And so what are the kinds of things that get in the way of Latinos engaging in primary care? We know that Latinos are likely to be uninsured or underinsured. There are many Latinos that don't have access to primary health care, largely in large part because of having inadequate sort of coverage in their insurance. But we also know that even when there is health insurance coverage, that it's difficult oftentimes to sort of maintain some Latinos in care. And if we think about the case example of HIV and primary care, how do we better engage HIV positive Latinos in being sort of in care, remaining in care, and becoming virally suppressed? And so I want you all to think about that. I'm going to be making some points and talking through some slides, and I want to come back to this because this really is sort of a big part of what we're trying to do in the curriculum. So another key concept is this socioecological model. Many of you may have seen this model. I think what's really quite nice about the model is that rather than think about things as only being at the level of the individual, too often we think that successes and failures are all sort of reflected as sort of individual decision making at the level of the person, and less so do we think about how is that individual embedded in a broader context, and that broader context may include things like interpersonal relationships with key members of their family, their community, their friendship circles, their healthcare providers, that in that interpersonal exchange, there can actually be things that occur that actually facilitate or hinder someone being successful in terms of their primary care. We also want to reflect not just on the successes or failures of the individual, but how do our organizations, where I work, where you work, how do the actual clinics, the actual social service agencies, the providers, how do the settings where we are embedded, do they support Latino HIV positive individuals with a criminal justice history doing well? Do they actually have procedures or practices or policies that hinder people being able to equally benefit from the kinds of services or healthcare that's delivered? The broader community, are there actual services in that community? Is there an overabundance of providers? Are there too few providers? Do we have the right kinds of services? Are folks sort of linguistically able to, communicate with their patients? And then the broader policy. We know that we've had big shifts in our policy, and so one of the biggest shifts has been around sort of the Affordable Care Act and thinking through healthcare access and whether or not all Americans, all individuals residing in our country, even those irrespective of their immigration status, can they have access to HIV-related primary care? And so I just give a couple of examples. You can see on the left that this socioecological model is designed to really incorporate not just the individual level, which is where most of us have tended to focus. We tend to see sort of patient or client successes as being really about them and what they do or what they don't do, versus really thinking through what I'm referring to as distal influences, and that in order to enhance engagement and retention in care, we really need to think about interpersonal, organizational, community, and policy. So here are some examples, and I think I've mentioned already some of these, so I'll very quickly just review. But again, a lot of where people focus tend to be at the individual level, where we look at patient decision making. So we might look at what kinds of beliefs do patients have about their healthcare or a particular sort of treatment, what kinds of attitudes they have, are they favorable or unfavorable. We tend to think somewhat about provider-patient relationship at this next interpersonal level, and so the kinds of interactions that patients have with their providers, with all of us, but also, what are the kinds of networks that our clients or patients are embedded in? What are the group norms? What kinds of supports do they have, or are they sort of absent of social supports? Those are things that we also need to consider. Organizationally, I've mentioned the context of healthcare delivery, the actual delivery system, what kinds of policies exist within the system. And then if you think about the community, certainly there are norms that many communities have, and so that doesn't exclude Latinos. There may be sort of issues around stigma, in particular HIV-related stigma. There may be problems in terms of healthcare access that are at the level of the community. I mentioned earlier that Latinos are sort of overwhelmingly sort of experiencing some difficulties in terms of accessing routine, regular care. And so they may be underinsured or they may be completely not insured. And that lack of insurance really sort of hinders their healthcare access. Policy is their criminalization of HIV. And so there are, I believe, 39 states in our country that have explicit laws on the books about people living with HIV and whether or not they've intentionally transmitted HIV to others, and how those laws could in fact result in them becoming incarcerated. And so how do those laws relate to prevention and treatment? I think we have some data that suggests that where there's greater level of criminalization, there's actually fewer people coming forward for testing, fewer people engaging in care, and there's more fear about making oneself known as being a person living with HIV. What are the entitlement eligibility sort of requirements, or how do people become at the local, state, or national level sort of eligible for certain programs, for ADAPT, for participation in a Ryan White clinic, for accessing antiretroviral treatment or pre-exposure prophylaxis? Are they eligible? And then, at the highest level, I would say, is our national HIV/AIDS strategy, which I'm going to actually talk about a little bit later. But we need to think about what's in these policies and how do those policies help to support the individual who's trying to make a decision with you as their provider and is really thinking through not just what their beliefs are, but is being impacted by their interpersonal networks, the organization where you're delivering services, their broader community, and at the highest level, all of the policy and sort of larger programs that are shaping their decision. So I'm going to go through and talk about Latino culture. And so this is interesting. I entitled this section Understanding Latino Culture. These are the things that most often are what I think folks learn when they think about sort of core Latino constructs. And so many of these things are going to hopefully resonate with all of you that are sort of watching and listening. But I wanted to sort of present these in a somewhat sort of nuanced way or with some caution. So first, I want to say I think there's a lot of what I'm going to cover that's true. But I want us to think beyond what could be described as a generalization or a stereotype, and I would rather place emphasis on some of the conceptual models that I'm going to be presenting later on in the curriculum. But I think it's useful to have some of this core content to think about in relation to the models. And so I don't want any way to confuse folks. I do believe that there's something useful and meaningful in what I'm going to talk about now. But I think what's more useful is to think about this next set of ideas within the context of some of the models. I'm going to come back to that, especially when we talk about in our next webinar, the case of Hector. We're going to be integrating some of this core content with some of the conceptual framework. So here are our cultural constructs that we're going to talk about. We're going to look at some cultural values. We're going to look at some Latino-specific interpersonal styles. We'll examine issues of collectivism and individualism. We'll talk about family structure and some family processes, particularly as it relates to gender roles. religion and religiosity, and then communication, both verbal and nonverbal. So another self-reflection, these self-reflections are great times to kind of take a break, to pause, to think about, some of what we've talked about so far. But in your own practice, how could cultural barriers be sort of represented, or how could they represent sort of a barrier or lead to miscommunication? And so again, just to kind of make that a little clearer, how can cultural differences maybe, rather than being something that is valuable and positive and constructive, how could they be understood as a barrier or as a form of miscommunication? In the past, how has your interactions with Latino individuals, your patients, your clients, have they had an impact on your care delivery? And how has your care sort of changed or varied based on your sort of experiences with your Latino patients? So these are some cultural factors that I think are sort of well documented and sort of often referred to in the literature related to Latinos. And especially if you think about Latino health disparities, oftentimes you'll see these cultural constructs. And so first and foremost, there is a tendency to talk about the Latino family as being an important unit. And so there's this notion of what's called familismo. And so you can see here on the slide, the familismo really is sort of Latino attitude or belief about interdependence, about attachment, about loyalty and reciprocity as it relates to the family. And that it isn't just among members of the nuclear family, but it's actually extended among a broader set of individuals that would be considered part of the extended family. For many Latinos, family is not just through blood. It can also incorporate a very fluid sort of boundary of who is considered a family member. And so that attachment and loyalty, that reciprocity, that interdependence, those things are often, sort of extended to people who are very close to the family, that may be family friends, who, when thinking about it from a familismo point of view, actually are seen as being family members and equal and equivalent to people who have a biological sort of connection to you. Another important Latino construct that's been well documented in some of the literature and research about Latinos is this idea of personalismo. So personalismo is the value that Latinos place on personal characteristics, on relationships, on warmth, on trust, on sort of issues of interpersonal connectedness, and really having sort of a foundation that is sort of cooperative, mutually sort of a reciprocity that is mutual, and then also sort of thinking through who you are as a person and whether or not you're a good person, if you're a respectable person, versus what your accomplishments are as an individual. And so if I think about my own family, so I am a professor at NYU, and I remember back in 2007, at the time I was working at Columbia University, and I was the first US-born Latino to earn tenure at the School of Social Work. I remember telling my grandmother that I had earned tenure at Columbia University, and I was really proud of that. I was really excited. I thought it was a great accomplishment. She didn't quite know what to think about it. I remember her saying to me that I was a good person and that I had done really great things to help people, and that's what mattered. And so again, it was this idea that, the sort of connectedness, the warmth, the trust, the character of who you are is more important than sort of your individual accomplishments. Another important Latino cultural construct is respeto. This is the importance of really thinking about authority and hierarchy, being respectful, thinking about elders, and having a responsibility, towards elders. Really thinking that everyone has sort of a position, a role, and a place, and that their social position is often based on their age or some sort of characteristic that should be respected. And so, respect may play an important role in how Latinos interact with their providers, in that we have a particular position as providers. And oftentimes your client, your patient might respect you, might see you as an authority, and might actually have some hesitance to actually raise some issues because of your social position in reference to theirs. Simpatía is this idea that many Latinos have in terms of avoiding controversy or conflict. And so rather than bringing up something directly, it may be easier to ignore it, to sort of let it go, to make a joke about it, to sort of keep things sort of harmony and harmonious, sort of really is at a premium. And it's better to keep things polite versus having a controversy or a conflict. And so I want us to reflect on these cultural constructs together. And so if you think about how this might apply to a patient or a client, your patient or client might be extremely focused on their family. They might be willing to do things because it's important for the family's well-being. There may be care that is delivered that rather than be focused on the individual, could be family-centered. They may really value their relationship with their provider, with you, your warmth, your character, how much they trust you. They may at times be deferent to you because they view you as having authority and because of your social position in relation to theirs. And there may be times when they avoid conflict and they avoid controversy because they don't want to disappoint you as their provider. And so that might mean that there are times when they go along with things and they really genuinely will follow through because their provider is asking them to do that. But it could also mean that there are times when they know that they're actually not going to go along, but they don't want to get into some sort of unpleasant interaction, so they don't say anything. And they just say that they're, claro que sí, I'm going to do it, no problem. But the truth is they're not going to. So I want to talk a little more about some of these ideas of core Latino constructs. And so in our US dominant culture, and I realize that this is, again, all this is part of what I said earlier about stereotypes and generalizations. So we want to be careful, but some of this, again, has been documented in the existing sort of literature that's out there. The US dominant culture really values personal goals and achievement. It values people becoming autonomous and becoming independent. And there's a high premium placed on sort of that pathway. So the pathway typically is that you sort of become more independent, you become more autonomous. If your life is going well, you accomplish more of the goals that you've set out for yourself. I think if you think about what has been sort of more historically associated with Latino experience, it's really interdependence within the group. And so within their family, within their community, within their church, within their neighborhood, within sort of a broader Latino community across our country or in the country of origin where they're from. And so the idea here is that there's a communal way, and that there is this idea that the collective benefit is better than the individual accomplishment. And that, if you couple that with what I said earlier about sort of the importance of the family or the high value that can be placed on character and who you are versus being more independent, more autonomous, and sort of personal goals being accomplished. So here's some examples of sort of dominant US individualism. And so when people say, here's my opinion, I think this, versus sort of group consensus, we think this. I think in sort of his traditional sort of dominant US individualism or in US sort of dominant culture, omission of truth often is equated with dishonesty. And so when you don't tell people something, people tend to feel in sort of US dominant culture that that's secretive, that it must be dishonest, you're lying, versus omission of truth for many Latinos means, preserving harmony. You didn't want to create a conflict, so you just didn't say what it was that you knew was going to create conflict. Confrontation is often not desirable among sort of Latino sort of collectivism perspectives. And so it may be more indirect communication. It may be communication that is less about I and less about really using direct language versus in sort of dominant US culture, confrontation is a form of voicing opinion. And that while done respectfully, that it's okay to have a personal opinion, and it's okay to state that directly and to actually voice that. And so, direct language for many Latinos is replaced with much broader terms. And so maybe, let's see, and so you as a provider are asking your patient to come for a follow-up appointment or see a specialist or to consider taking a medication, and they say, let's see, or maybe. And so what does that mean? That may mean that they are really going to think it through, or it may mean that they know they're not going to, but they don't want to have a conflict and they don't want to directly confront you and share that they aren't in agreement with the plan. Group identity is highly valued. I know that I am very much proud of being a Latino, of being born in the Bronx, of having a mother that is from Puerto Rico, and that's something that is always with me and present, versus individual identity, which is often sort of much more associated with the dominant US culture, how people see themselves in relation to others versus sort of being part of a group identity. I think the inner qualities and self-respect and respect from others, those are things that are very important to traditional Latino collectivism cultures versus personal identity being largely based on individual achievements. And so these are things to kind of think through and to add to sort of our knowledge toolkit of things that we're going to want to apply to the case studies later on. So family structure and processes, I mentioned earlier that there's this idea of a collectivist culture, reliance on the family versus the formal health or social service system. And that family can extend to networks that are not just the immediate nuclear family. These relationships are often warm, they are very personal, they are based on respect, and there's sort of a high value placed on what's considered family honor. They can often be inclusive, as I mentioned previously, of folks that are related through blood and marriage, but also they can be what are known as informally sort of adopted people or children, hijos de crianza, compadres. These are folks who are not the nuclear family, they're godparents, they're co-parents. They're folks who become part of our network and part of our families who we bring in and who we see as being no different than biological family members. Oftentimes gender roles comes up when we think about Latinos, and so there's this notion of machismo, and then sort of the opposite side of that is Marianismo. And so machismo has historically been kind of described negatively, and so it's really been talked about as somehow being sort of a bad thing. It's sort of typically associated with males who are aggressive, who are aloof, who are sort of risk takers. But I think there's a positive side of machismo that doesn't get talked about as much. And so here the idea is that Latino males can be responsible, they can be confident, they can play a leadership role and have a sense of obligation and responsibility for their families. They can be instrumental in deciding things for the family and sort of being, sort of responsible for thinking about the collective unit. And that's in no way to minimize or to suggest that some of the negative aspects of machismo aren't also important to consider. But I want to just let everyone sort of think through that it doesn't always have to be that machismo is something that's negative. The opposite is Marianismo, and this is sort of the idea that is often associated with Latino women as being humble, as being very feminine, the idea that women are expected to maintain sort of an appropriate distance or be deferent to men, and that some of this can actually be sort of played out when sort of interacting with sort of a Latina female and you're a male provider, or if you're interviewing, for example, a couple that is a male and a female, the kinds of issues that might come up when you're talking about sort of decisions that the Latina female has to make about her health care. And so again, just to kind of think through these, both the positive and then also the potential negatives that can be associated with gender roles. This is pretty straightforward. I'm going to come back to the case example of Puerto Ricans, but I think this is just a really quick reminder that there are certain religious holidays and celebrations that are recognized in the continental United States but oftentimes there are days that are part of specific sort of cultural groups or ethnic groups, sort of traditions, their holidays, their religious celebrations that don't actually get recognized. And so I think it's important for providers to think through that our organizations might have a practice of being open on these days or providing services on these days. These are days that probably are not going to be the best days for clients that actually celebrate these holidays to come and see us. And so important to remember the majority of Latinos and Puerto Ricans are Roman Catholics, that religious and sort of holidays and celebrations among Puerto Ricans and Latinos more broadly are often focused on family gatherings, and they're important to consider because, as I mentioned, it's unlikely that your patient or client's going to come in on those days. There's a listing here. I think that there are some that I think are pretty straightforward. Certainly most folks in the U.S. may be thinking about Hanukkah or Christmas. You can see here that December 24th, Christmas Eve, is particularly important for Latinos. You can see here that there may be Good Friday is an important time for Latinos. Semana Santa, which is Holy Week. It can often be the entire week. I think Palm Sunday, or Domingo de Ramos, Miércoles de Ceniza, Ash Wednesday, the Carnival, Dia de los Tres Reyes, Three Kings Day. I remember as a child having a basket under my bed that my mother used to place for the three gifts, and when I woke up, there would be three gifts underneath my bed. These are all things that were not widely celebrated by my peers and by folks that were not part of my Latino culture, but they were things that were actually quite important in my own family. And I think for many Latinos, these religious holidays and celebrations have deep meaning and are likely to be days when they're not going to come to your clinic or your service. So I want to talk a little bit about communication. And so, many Latinos are bilingual. And so I think that, they may speak English, they may speak Spanish, they may speak both. And so here's a sort of snapshot of foreign-born and U.S.-born. You can see over time that there have been some changes. And so in the U.S.-born from 1980 to 2013, you can see that speaking English has definitely very well. It has improved. That's also improved for foreign-born. And you can see also speaking Spanish, for U.S.-born has slightly gone down, but for the Spanish, for the foreign-born, speaking Spanish in the home has pretty much stayed the same. And so again, it's just showing the importance of language and that the need to consider, whether providers are bilingual, if they have interpreters, and to really be able to align the sort of language preference with the person that you're seeing in care. Communication can also sort of take on different forms, and we're going to talk about direct and indirect forms of communication. I wanted to spend a second just sort of talking about Spanglish, and this can be sort of a mix of Spanish and English words that can often be spoken by many Latino groups, not only Puerto Ricans, but many Latino groups that have had a lot of exposure to the U.S. broader culture. Words and language has a way of sort of evolving and changing in time. And so it's not uncommon for many words that are quite dominant in sort of the English language to find their way in the Spanish language and vice versa. Something that is really interesting is this idea of what we want to call high EE families or individuals. And so high EE individuals are folks who might express themselves with a higher pitch. They might have more pressured speech. They might have greater volume, and because of that, they're seen sometimes as actually having an anxiety experience, or somehow their expression of, their communication is seen as an expression of distress. And I think, rather than seeing it as just a form of normative communication, I think we need to be careful about sort of how we're understanding what might be unfamiliar to us. Here are some nonverbal ways of communicating that I wanted to also just introduce. Again, these could be understood as stereotypes or generalizations. I don't want to say this is true of all Latinos, but there are things that have been documented in literature that we should be sort of, really familiar with. So, in dominant US culture, there's a high value placed on punctuality. 1 o'clock is 1 o'clock. For many Latinos, there's a relaxed attitude towards time. 1 o'clock is sort of around 1 o'clock, anywhere from 12:45 to 1:30. And so there's a range there. Physical contact is common. It's a way of sort of greeting each other, hugs, and sort of showing sort of a positive warmth and regard through physical contact versus, there being less physical contact in dominant US culture and there being more boundaries. Subtle hand gestures while talking. If you notice a couple of times during the webinar, I actually have moved my hands. That's actually, big hand gestures are actually pretty common among Latinos. Subtle hand gestures or not moving your hands at all is actually much more common among the US dominant culture. I know in much of my communication with folks that when I move my hands, people become distracted by my hands, and so rather than focus on me, they're looking at my hands. And so over the years, I've learned to actually sort of manage that by keeping my hands still. But when I'm not doing that intentionally, if I'm just talking to people who share similar cultural experiences I do or who may understand my cultural experience, it's not uncommon for me to move my hands. Direct eye contact may be avoided, so looking away, looking slightly away, taking pause to look away and then look back, versus direct eye contact in dominant US culture being a sign of respect, being a sign that you're focused, that you're paying attention. Personal space is highly valued, and so in US dominant culture, there's this idea of my space, your space, versus differing views on sort of how comfortable one is with personal space. And so for someone who is more traditional in their Latino cultural experience, it may be that standing close together is much more acceptable than really maintaining, more of a separation between sort of patient and provider. Interrupting during talking is okay. I know that I pretty regularly interrupt people when I'm talking with them. It's not something that is done to be rude or in any way to suggest that I'm not listening. It's actually a form of engagement. It's a way of letting them know that I'm really actually quite engaged in the conversation and that the conversation has meaning for me. In US dominant culture, interrupting is something that is seen as being rude. Oftentimes, folks get angered or bothered by being interrupted. They want to finish their thought before you respond. And so, again, being aware of that when you're a provider, your patient or client might interrupt you, and it's not that they're not listening or they're being rude, they actually are doing what is considered normative. Silence when talking is okay, no response, or silence during talking is not okay. And so you can see here in the US dominant culture, there's more of an expectation that you will respond and that you will actually say something versus, silence being something that is okay. All right, so I'm going to transition. We're now at the place where we've gone through some of the big knowledge and sort of core content and ideas that are, again, some facts or things I want you to keep in mind, but they're not the frameworks. And so I want to spend the next part of our webinar looking at 4 frameworks. You can see them here on the slide: the culture of formulation, transnationalism, the DECIDE model, and shared decision making. And I want to go through and present each of these frameworks and apply it to cultural competence with an eye towards how can these frameworks help us to engage and to retain our HIV positive Latino criminal justice involved patients or clients in care. So let's start with the cultural formulation. This is a really terrific model. I first became aware of this when I was in social work school here at New York University as a student many years ago, and the model still has relevance. It was developed by a team, and one of the core sort of architects of the model is a psychiatrist named Roberto Luis Fernandez, who does a lot of mental health work at Columbia University. And the model is really important because it can be really useful in understanding cultural factors that can shape an encounter with a patient or a client. So we have interactions with our patients and clients, and we need to think about how that interaction can be shaped or informed by cultural factors. It's particularly useful when the provider doesn't have the same cultural background as the client. And so there are many times when I'm working with an individual who I have a different background from. And so I need to think about what tools I can use to help understand how to better provide culturally appropriate care. It also expresses some boundaries between the patient and the provider, and it examines those boundaries. It formally looks to see, are these boundaries appropriate from the point of view of a cultural perspective? And then it also looks at how cultural factors shape symptoms and how cultural factors may shape health-seeking behaviors. So there are 5 steps, and they're here on the slide. I'm not going to read each one of them because we're going to go through them, but I want us to go through and actually consider the 5 steps. And then later on, we're going to do a little case study where we're going to apply the 4 frameworks, including these 5 steps, to the case of Hector. So step number 1 is cultural identity. When we have a patient or a client, we need to think about, well, what is the individual's cultural reference? How do they define themselves, both in terms of their ethnicity, their race, their membership in particular cultural groups? What is their level of identification with both their culture of origin and also where they currently are, their host culture? Keep in mind that we often focus on ethnicity and race, but it could be other things as well: religious affiliation, their sexual orientation, their experiences as people who have been criminally justice involved, their language abilities, their use, their preferences, including Spanglish or multilingualism. I think these are all things that we need to consider when we're looking at identity. Who are they and how do they define themselves? The next is, what kinds of explanations do they provide for the meaning of their illness or disease? For our purposes, it's HIV. And so how do they understand their HIV disease? How do they perceive the severity of the symptoms they have in the HIV-related symptoms? And how do those symptoms get understood from a cultural lens? How do they think about what the causes of their illness are? And what explanations do they give for that? And then how do they experience healthcare utilization? And how does their culture inform their healthcare utilization? Step number 3, the psychosocial environment and their functioning. And so what kinds of stressors are in their local social environment? How do things like their networks, their sort of religious affiliations, how does that play into their emotional, instrumental, and informational support? And then also, are there any interpretations of social stressors, social support, and levels of functioning disability that are tied to cultural factors? And so we're going to look at that in our case study. And then the provider-patient relationship, which is step number 4. This is actually a really important one for all of us. This helps us to think what kinds of differences exist in status between patient and provider, and how can these differences inform our sort of treatment planning, how we diagnose or frame the problem, how do they sort of get in the way or help us to talk about symptoms or understand the experience of our patients or clients in terms of what the cultural significance is. How can we decide if behavior or a certain sort of way of doing things or engaging in care is normal, or is it representative of sort of failed treatment or representative of the illness or of a bad outcome? These are things that are also important to consider. And then last is we take the first 4 steps and we sort of bring everything together and we actually make an overall cultural assessment. And that overall cultural assessment is, how are we going to specifically take aspects of this individual's culture and how are we going to use that to inform their diagnosis, how we think about the problem, how we align, how we deliver care, and the kinds of things that we're going to do to engage our client in care to what they've laid out in the first 4 steps. Transnationalism, we've talked about that a little bit, and so this was an actual tool that Janet Worsima and her team, along with Allison Jordan at Rikers, developed. And so this tool was something they were using at Rikers Island. It had 5 simple dimensions or transnational elements that are important to understand. These elements are not intended to be independent of the cultural formulation. The 4 frameworks that I'm presenting, they can be used in a complementary way, or they can be used in an additive way, or they can be used independently. But I think they're just 4 examples of the importance of trying to get a handle on cultural competent care. And so here's another way to think about that. So the 5 steps include understanding the patient's background, their travel patterns to and from their country of origin, if they send or receive money from family members or from loved ones in the country of origin, how do they identify themselves and how do they view themselves? And then how do we think about their discharge or their treatment planning from the point of view of this transnationalism perspective. And so let's use the example of Puerto Rico, and let's use an individual who is born in Puerto Rico, and let's go through each of the transnational elements. So the first one is background. So here are some examples of things that you might want to ask someone. Were you born in Puerto Rico? Where were you born? If they're born in Puerto Rico, how old were they when they first moved to the continental US? Why did they leave Puerto Rico? Have you ever lived in Puerto Rico if you were born in the continental US? And if so, how long? If your parents were born in Puerto Rico, what part of Puerto Rico? Where are your parents now? Where are most of your friends, your family members? Where are most of your connections? These are all things that can help you get insights into their transnationalism identity. These 2 starred points, they were points that Janet and her team found to be particularly helpful when thinking about their Puerto Rican sort of clients that were incarcerated on Rikers Island and this sort of transnationalism perspective. And so it was really important in terms of treatment planning to ask explicitly about how often do you travel to and from Puerto Rico? And then assuming that you don't travel to Puerto Rico, would you like to travel to Puerto Rico more often or less often? Can you explain that? And why don't you travel to Puerto Rico more? What are the things that get in the way? These are questions that can provide insights into what's likely to happen when the patient is trying to engage in care and they may in fact be planning or actually traveling away from where their care is actually located. Sending and receiving money. How often do you send money to family or friends in Puerto Rico or anywhere in Latin America? And does your decision to send money, does it interfere or does it help you in terms of your health care or your lifestyle? And so if you're spending most of your income, you have, let's say, a sort of modest income on sending money to family members or to loved ones, that could have a potential negative impact on your own care. And so it's important to ask, does money that you receive from family or friends in Puerto Rico, does it interfere or help your sort of health or lifestyle? And what are you spending the money on? What is it for? And is it possible that some of what you need money for is actually you're not able to provide because you're responsible for loved ones elsewhere? Okay. Ethnic identification. So here the idea is, how do you prefer to think about yourself in terms of identity? Is there more than one way? Are you Puerto Rican? Are you New Rican? Are you Boricua? Are you Hispanic? Are you Latino? What exactly is your identity? How does being New Rican affect your HIV medical care and other services? Do you think that because you're a New Rican, you receive different HIV care, treatment, or other services? And so again, this is a good example of how you want to think through how does their ethnic identity potentially shape how they understand their healthcare delivery. Discharge planning. How serious are you in returning to Puerto Rico at this time? Do you have a transnational plan? Are you going to go to Puerto Rico? If so, would you rather be connected to healthcare services and primary care here in New York City, for example, or in Puerto Rico? And, are there agencies that, can help, you specifically in Puerto Rico with the kinds of issues that you're, perhaps needing to actually access, right? Or that you're sort of working or struggling with. So housing, substance use, your medical care, and then other kinds of services that may be needed. Okay, so I want you to take a second to self-reflect, and I want you to think through if there's a time that comes to mind when you've thought about a cross-cultural situation, and what do you believe was the most significant challenge to that cross-cultural engagement, and how did that sort of play out, and what was the cross-cultural involvement? So our next conceptual model is the decide model. And so again, I just want to remind everyone that the intention here is not to have you do all four models with your patients or clients, but it's to provide different examples of ways that you can kind of get at the same things. And so we've done the cultural formulation, we've done transnationalism, and we actually want to do two more models. The first is decide, and the last is actually my favorite, which is shared decision making. And so let's talk about what decide is. And so this model is a framework that increases patient or client activation and self-management. And so this is what we want. We want our patients to be engaged, to be activated, and to support their health and well-being through self-management. And so patient activation, it really refers to the acquisition of knowledge and skills that enables patients to actively engage in questions and decision-making about their health and treatment. And self-management is when patients manage their own health by increasing awareness of factors that could help or perhaps get in the way of their health outcomes. And so DECIDE is a particularly useful model. It's broken down into this sort of useful heuristic decide. And so we're going to go through each, but it's basically deciding on exactly what is the problem, how do we explore through questioning, are patients asking sort of closed or open-ended questions, how do we identify the who, the why, the how of what the problem is, how do we direct questions to the healthcare provider, and then how do we also develop and share a joint solution. And so here's the model on the left-hand side, and then here are some questions that I want you to think as you try to apply DECIDE to your patients or clients. And so deciding on the problem. So how does your patient actually describe the problem? Do they see it as a problem? Do they see something that is actually quite different than what you as the provider see? How do you explore sort of questions related to the problem? Okay, so what questions would you ask the patient to better understand their circumstances? And how would you frame your questions in a way that actually invite the patient to ask you questions and then also help you to understand the patient's circumstances? And so the next piece is really thinking about how is the patient asking you questions? Are they asking you questions that are open or that are actually closed-ended? Are they very focused or are they broader? This next piece relates to the very first thing that we talked about when we talked about the DECIDE model, which is how does the patient actually understand the problem? And so what are the sort of aspects of that? The who's involved in the problem? Why is that problem happening? And how did that problem come to be? And so if you think about it, if we just pause for a second, a lot of what we're getting at DECIDE is actually pretty similar to the cultural formulation and transnationalism in terms of getting a better handle on how your patient or client views the current circumstances that they're in. But this is, again, a slightly different sort of perspective that's getting at sort of more involved around sort of helping the patient become engaged or to improve their self-management. And so the next piece of the DECIDE model is directing your patient or helping your patient or client to ask you questions as their provider. And so how can you provide direct and indirect assistance to your patient's questions or concerns? Are you responsive? And how can you facilitate or invite them to actually participate? And then what are the possible solutions? And this is one that I really want to kind of highlight. So enjoying a shared solution. Many of the problems that our patients or clients face, there are multiple avenues. It's not just one road forward. And so it's important to think about options. What are the possible solutions from both the patient and provider perspective, and how can there be sort of a joint shared solution? So how do we apply this? I think a way to apply this is our fourth model, and so I'm going to kind of put shared decision-making and DECIDE together. And I'm going to give you some specific examples where I'm going to apply what I might say, what I might do, and it's going to build on what we've been talking about with DECIDE. And so shared decision-making. So shared decision-making, it's a collaborative process that allows patients and their providers to make healthcare treatment decisions together, to take into account the best scientific evidence possible, but also, and this is really important, to understand your patient or client's preferences and values. And so again, in order to support self-management, in order to support greater sort of patient or client activation, we need to bring what we as providers bring to that experience. We have some information, some scientific evidence. We have the option of providing a treatment that could in fact be potentially beneficial to the patient. But independent of our perspective, our patients have their own values and their own preferences, and we need to think about how we can bring these together through shared decision making. Shared decision making provides patients with supports. It helps them to make the best decisions. Our patients, they are the ones who need to make the decision for their specific needs, while allowing providers to feel confident that they can actually provide perspectives on treatment, okay? And so really important here, I just want to stop for a second and highlight that the shared decision-making model is really about our patients deciding, and they're going to make decisions that are based on their specific needs, but we as providers can feel confident that through shared decision-making that we can lay out some suggestions that are based on scientific evidence or best practice, but also formally take into consideration our patients' or clients' values and preferences. So let's consider another self-reflection. I think this will be our last one for this first webinar. And so what are some of the barriers to shared decision-making? Okay, and some examples of that I know that have come up in my own practice is that there could be, for example, a difference between how I view the problem, how I view the treatment or the best course of action, and how my patient or client views it. I may want them to come to appointments every 6 months. I may want them to take an antiretroviral. I may want them to use the barrier method correctly and consistently. I may want them to be on prophylaxis for an opportunistic infection. I might want them to have a vaccination for prevention of an opportunistic infection or something that we know can be prevented through vaccine, but they may not feel the same. They may have concerns, fears, have a different course of action that they prefer that is more consistent with how they view what their healthcare priorities are. There may be inconsistencies between the provider and the patient in terms of their treatment decision readiness. As providers, did we actually help our patients to be ready? Did we do the necessary implementation support work that would allow the patient to make an informed decision? Or there may be stigma. We often don't talk about this, and if we do talk about it, we tend to talk about stigma on the part of the patient. And we say patients have stigma about their mental health or about their HIV status or their substance use. But the other part of that is that providers also can have stigma about their patients. They may have certain views about how they view their patients and how they actually view the circumstances or the risk or the exposures that the patient has actually acquired in the course of their HIV disease or their incarceration that actually is not necessarily supporting their patient's care and health and well-being, and may hinder it or may get in the way of it. So here are some steps, and these 6 steps are what we're going to cover together. And I'm going to actually give some pretty straightforward and simple sort of word choices of things that I thought were particularly useful in my own work with adolescent HIV positive Latino individuals. And so I want to just remind everyone again that the 6 steps are part of this sort of shared decision-making process, and that process, again, is collaborative. We make decisions together, and that it reflects both the scientific evidence and best practice and also our patients' values and preferences. And so you can see here on the slide that it's highlighted patients' values and preferences, making decisions together, and that it's collaborative, because I want to make sure that together as a group, as folks that are participating in the webinar, all of us collectively, that we're thinking about sort of the real sentiment of shared decision making as we review the 6 steps. So the first step is formally inviting your client or a patient to participate. And so we know that as providers, we're busy, we have many people that we're taking care of. We may feel overwhelmed. It may be easier just to prescribe treatment and tell our patients what we expect them to do. But the truth is, we actually need to invite our patients to participate. We need to offer them the option of, being involved and being involved really actively. Let them know that they have choices and that those choices are going to require them to get involved, to take action, to weigh in on what they want, that they have goals and concerns that are sort of an important part of the decision-making process. Here's some simple language that I found to be really useful. And so you might say, sometimes things in sort of healthcare aren't sort of as clear as what people might think. And so let's work together so we can come up with the decision that's right for you. Right? Something very simple and straightforward. One that I really like and that I usually say pretty regularly is I will ask adolescent patients, well, what do you want to get done today? What's your priority for today? Is there anything that you want to make sure that I help you with today that's on your mind? Okay, and so again, it's formally inviting them to participate and letting them know that they have sort of a role in the process. The next is presenting some options. There's never just, or more often than not, there's never just one choice. And so you want your patient and your client to make an informed decision. They need to know all the options that are available to them, not just the ones that we as providers think are best, but all the options, even the ones that we don't think would be the best course of action, but they are certainly options. And so some simple language for saying that is, here are some choices that we can consider. Or I might say something like, well, let's take a few minutes to review the options you have. It's not just one sort of choice. There's actually a couple of things that you can decide, and I want to review those to make sure that you pick the thing or the option that's best for you. Provide them with benefits and risks. And so again, we want to be really balanced in our information. We want to make sure that we have sort of bias-free information, that we want to make sure that when we provide balanced information, that our patients and clients understand the potential benefits and the risk. And so we want to review each of those. Here are the things that are good that could happen. These are the positives, the benefits, and here are the things that might not be so good, or that could be risk or challenges that could happen. And you want to make sure that for each of the options that you've reviewed that carefully in a way that's balanced and that's as bias-free as possible. Let's go over the benefits and the risk of the options that you're considering. That's a pretty straightforward, simple way of saying it. Or I want to be sure that I, as your provider, that I've actually explained things well. And so please tell me what you've heard, and tell me what you hear as being the most important benefits, or what do you see as being the most important harms. And so these teach-back methods, these health literacy checks, these are ways of making sure that our patients understand exactly what we're presenting as far as options. And I'm often surprised at how I say, well, I don't know if I explained it so clearly. Can you tell me what you understood from what I said? And oftentimes patients are able to tell me accurately what I said, but it's also true that often there are circumstances when I've said something and it wasn't understood correctly. And so it gives me a chance to say, hey, I don't think I explained that well. What I really meant was, and I can clarify and say, how does that sound now? What do you think? Does that sound different to you? What do you understand? The fourth step is evaluate the options based on your clients' or your patient's goals and concerns. And so being really clear that you're addressing formally the patient's concerns and their goals for treatment. I started by saying that I like to ask adolescents, what do you hope to get accomplished today? What is most important for your visits today that you want to make sure that we get to? You want to actively inquire. You want to give them permission to speak about what's important to them. You know that once you've asked them this information, you can help them to then look at what options exist and what their preferences are, but you won't have that option if you don't actively engage them in trying to understand what they see as being important. People have different goals and concerns, and so again, that's a really simple, straightforward way of stating it. And so I want you to think about your options. What's really important to you? Is it important for you to have a once-a-day regimen? Is it important for you to have a regimen that you can take at any time? Is it important for you to have a regimen that you can take with or without food? Is it important for you to have a regimen that's likely to not develop resistance if you forget a pill? I mean, those are all things that we have to explain and help the patients to make the best informed decision based on their life and what they think is important for them. And so, I might say to a patient or a client, for example, some people actually might like this or choose this, while others might like this or choose that. What do you see as being important for you? What matters most? And then this is actually the next step is really facilitating deliberation and decision making. And so this is about laying those options out, but then helping them to actually have the necessary information that will allow them to deliberate, to consider, to weigh out, to balance. And so patients may not be ready to make a decision when we first bring the issue up. They may feel like it's too new, there are too many options. They may not feel like they have all the information. And so a lot of the times we want to plant a seed, introduce the topic, and then we want to formally probe. What else do you need to know before you feel like you're able to make a decision? What other information could I provide, or what else would be useful to help you come up with what you think is the best plan? And so, again, some simple language. Consider what we just talked about. Consider what we've been talking about. Do you have a preference on what direction you want to take? Is there any more information that I can get for you? What do you need? From what I hear you saying, here's what I'd suggest. How does that sound? Again, you're helping to facilitate deliberation about a decision-making process and helping your patient or client to come up with a course of action. The last one is one that often I think gets dropped, and that too often I don't see enough providers actually carrying this through. And so now the decision has been made. The treatment plan has been established. The referral has been identified. And so you want to close the conversation around shared decision making with your patient or client, where you lay out the next steps together of what's going to happen. And so you want to make sure that you're assisting with implementation, and then you're not just developing the plan. And so there are two things that are really important here. You want to lay out what the plan is, and you've done that jointly with your client or patient, but so you also want to assist. And often providers may lay the plan out, and that the responsibility for follow-up and implementing the plan is primarily falling on the patient. And while we do want patients to be involved in their care and to sort of adopt self-management, helping our patients to implement their strategy is something that I believe is very important, okay? So let's take a moment. Let's talk about next steps, and let's lay out what might be the best course of action. What can I do as your provider to support you with the next steps? Are there specific things that I can do that will assist you to be successful in implementing the plan that you've identified? So here's some examples of things that are sort of do's and don'ts, sort of the thumbs up or the thumbs down. These are things that we want to highlight for the 6 steps. And so, routinely provide scientific, evidence-based care that's unbiased and that really invites your patients or clients to engage and to easily understand what you're trying to sort of communicate to them. Share useful information, help them to deliberate, help them to know what the options are, help them to think about what they value, what their preferences are, how those values and preferences fit into their culture and their lifestyle. Those are all things that are terrific, and they're all going to be part of the shared decision-making process. If we just stop for a second here and think about it, if we take those 2 last points that are reflected on the slide on the left-hand side, we could put together the cultural formulation, transnationalism, and the decide model. And it kind of really boils down to this. You want to, invite your patients to participate. You want to elicit from them what matters. You understand who they are, what their values are, what their lifestyle is, how their culture plays into this. And you want to make sure that you're giving them the best practice or scientific sort of guidance that you can provide, while really taking into account their preferences and their values. And so some of the sort of not so great examples is that you as the provider, you fully know, you fully understand, you are able to prescribe the patient's values and what you think is important for their lifestyle, and that given that you have the evidence base, that's kind of the way that things should be. And so that is likely to result in less shared decision making, less culturally competent care, and sort of poorer outcomes. Also true is that you shouldn't assume that your patient understands their course of action, their treatment, their condition, what the plan is. You've got to elicit their perspective and make sure they can teach back what they've understood and help them to access more information about their choices, and that they really understand that they have options available to them. I want to end by saying thank you very much. This is the first part of the webinar. There's a second part that's going to cover modules 2 and 3. What you see here is my email, vincent.ramos@nyu.edu. I hope you've enjoyed this first webinar. Thank you very much.